A very good morning. Welcome to the first live session of Bangladesh Radio Live 2023.
That is 15, not 20.
Yeah, 15.
I am very gratified to announce the name of the operator, Dr. Barnhedo Cortesi. He is a world-renowned interventional cardiologist. He has expertise in the field of DCB, OCT, and left main revascularization. To chair this session, we have very eminent and distinguished cardiologists from home and abroad. I request Dr. Tejas Patel, Dr. APM Shohrabuzzaman, Dr. Maksumul Haq, Dr. Somir B. Panchwali, Dr. Pratap Kumar, Dr. S.M. Mustafa Zaman, Dr. DM Azam,
Slowly at 3, 4.
Dr. M.J. Azam, and Dr. Tamzid Ahmed to chair the session and come on the stage to take their seats.
6.
Good morning. I also welcome you all in this session of live transmission. And panel of experts of this session are Pradeep Kumar Karmakar, Tawfiq Shahriar Haq, Dr. Mohammad Busali, Dr. Tanjima Parvin, Dr. Sabina Hashim, Dr. Nurul Alam, Dr. Mohd Shahabuddin. And I'd like to request all the panel experts to come on the dais and have their seats.
Yeah, now it's better. 9, 10, 12. So the lesion is calcific.
Yeah, calcific, right. Balloon undilated.
Yeah. 14. It's this is a semi-compliant.
Yeah, semi-compliant.
Okay. 14. Okay.
Now I am requesting the chairperson to chair the session. The case already started in and directly transmitted from NICVD, Catlab.
Welcome to LICVD.
Okay, so again, 2,
As
3,
online
2,
moderator,
3, 4.
we have
Can
Dr.
we have on the
Pidano
right
Ramamukunda.
the
Can you
angel, please?
Can you please show us the case,
Okay.
Dr. Nizam?
Our case, Muslim Mondol, 58
10,
years old,
8,
hailing
10.
for Pangsha Rajbari with the complaints of exertional chest pain
Down.
for 3 months and with palpitation. He has no history of hypertension and diabetes. He has a history of non-STMI 6 months back.
Okay.
His
let's
ECG
take a
shows
shot
ST
now.
depression
Okay, sure.
in lateral leads. All the other investigation is normal. Echo shows no regional wall motion abnormality with the
So,
EF of 63%.
I think we need a scoring
Yeah.
balloon for this.
This is his angiogram
Ulberian আছে?
showing left system.
Come on. Ulberian 2.5.
The
Yeah.
LED is ostial disease,
Yeah.
and there is a in the proximal part there is an aneurysm,
scoring,
and
what
there is
What type of
also
scoring do you
a
have?
111 bifurcation
Wolverine.
lesion with
Boston
D1,
Scientific.
and
10, okay.
there is also an aneurysm after the lesion.
So you will do the presentation.
And this is the right
of
system.
The team of the people when we start, and then we discuss.
Yeah.
So we are going to back to Mr. Cortesi, sir. You can go.
Hello. Good morning. Can you hear us?
Yes, Bernardo, we
Yeah.
can hear you.
So, yeah, we have a quite complex case here. You have seen we are going to face this aneurysm, the double aneurysm actually in the LAD
2.5.
with a diagonal branch originating from the aneurysm itself, and also a proximal LAD, which by the angio is not very nice. So we have done an IVUS analysis. If you can show, yeah, we can take off the right. We don't need it. So if you can show the IVUS.
I was Shimon.
The pullback. So we did an analysis from the distal part of the vessel through the ostium. Can you see it?
Yes, we can see the IVUS, yes.
All right. So there is a calcification just distally to the aneurysm. Great. So we are, yeah. And then we have the aneurysm, which is pretty big. Okay, and then coming out more proximally, as we expected, there is a significant lesion in the ostium of the LAD, a short one, but the lesion is there, with some, I would say, not so severe calcification. So we took an area there, which is 3.6. I think you can see it. Yeah, 3.61 is the area of the ostium of the LAD. So now we have two problems in these patients with stable angina, which are the aneurysm, the subocclusion of the vessel, and the ostium of the LAD. So we have some ideas, but I would like you to comment on these and give us your feedback. So let's go ahead. In the meantime, we go ahead if you don't mind.
Please go ahead. Yes, so we do see some 360 calcium almost, and also areas of some negative remodeling throughout in some segments of the vessel.
Okay.
So what's going to be your strategy as far as modifying the lesion first?
Yeah, that's the first part. But let's discuss about the final strategy. Actually, I don't know if we are too optimistic, but we would like to spare putting any metal in this aneurysm because, malapposition is not a good thing. So the idea is to prepare the lesion and see, and if we are able to prepare it correctly, we will try to use only drug delivery by means of DCB. This is the idea.
Bernardo, actually, I have a question because it is not that deeper a calcium. The calcium can be easily tackled by, even though it is looking like a almost 360-degree calcium, but it can be managed by cutting balloon because I can see the area behind the calcium. So I think it is not that thick a calcium. It's a thin rim of the calcium. So it can be managed by a cutting balloon. That will be my approach. After the cutting balloon, you told the aneurysm is actually the major critical point here. So your idea will be after cutting balloon, putting a drug balloon and coming out, or what is your strategy in your mind?
Slowly, 2, 3. Yeah, the idea is, we totally agree with you. We try to open 4, 5, open a little bit with a semi-compliant balloon at 2.0, which actually did not expand well and set down. And so we are now crossing to a cutting balloon. What you can see here now is a 2.5 Wolverine 2.5 by 10. So again, please 2, 4 slow inflation.
I also request Professor Dr. Mohammed
look at the balloon now. It's not expanding very well. So 4, 5
as a chairperson.
6. Look at the the resistance of the calcification to the expansion of the cutting. 7, 8. We go slowly. We don't want to create big dissection here.
Now, there are two things
Or
in the
perforation, which is even worse. Do you have a coverage
One is
test
actually
here? Perfect.
you grow gradually from 6 atmosphere. You can go even up to 12 or 14. You should keep the balloon inflated for nearly 10-15 seconds. Then only you will get the effect of the.
So now the balloon is inflated by 30 seconds. So we are at 9, 10, 11. So we agree that we don't need specific treatment for this calcification, at least as a first approach. So we try with the cutting. Let's hope we don't need other. Okay, down, slowly down, please. Thank you. So this, I think, was the worst part. Now we can take a shot in the end. So
it's only a semi-compliant balloon or not a cutting balloon?
Yeah.
This is a cutting balloon. Okay, so let's go.
2.5, 10.
Wolverine 10, 2.5 into 10, right?
On the right.
Yeah, 2.5, 10.
On the right. Put the angel, not the inflation of the balloon. Just the angel. The still angel, please. Yeah. So this is a 2.5 by 10 cutting balloon. Now let's take a picture.
Okay.
Let's take a picture. So we did a very slow inflation in the lesion. Yeah. So we have created a nice dissection distally. There was a reduction in the lumen. You can put this one, the last one. You can put it on the right.
Last one recorded.
Still, the lesion is not well prepared. I think just after the aneurysm, So we will try to tackle it a little bit more with this same Wolverine. What do you think? No, we need the basal angel on the right. No.
Okay.
No. Yeah.
This one.
Perfect.
I think from here it looks like there is an area right above the diagonal ostium where the Wolverine is not fully expanding.
Correct. Small test. So now we are here again with the cutting. And so again, let's go at 2, 3,
4, 5.
5. Now we go a little bit more.
5.
6, 8.
Same Wolverine.
12. Excuse me?
Say same Wolverine?
Yeah, it's Wolverine 2.5. 14.
Now you go
16.
air pressure.
Yes, yes.
Yeah, it's a little bit better.
Yeah,
Huh? What do you
yeah.
think?
I
17,
think
18, 18, down.
down, slowly.
Slowly down, please.
No, but actually, that is what I'm telling. When you do a cutting balloon, you have to keep the cutting balloon inflated for 15 seconds. Then only you will get the effect of the cutting balloon. Otherwise, you deflate
yeah.
immediately. You don't
Correct.
get the benefit.
Let's go again
Yeah.
here.
2, 4, 5.
6. Yeah, this is what we are doing. Slow inflation. If you want to avoid stenting, use
Stand
slow
close.
inflation. Okay. Yeah, slowly go to 14, 16. Very slowly, progressively.
16.
So the balloon actually opened it up a little bit better. What do you think?
Actually, Bernardo, after the balloon inflation, you want to see that it is
Okay,
produced
down.
an effect or not.
Slowly.
You have to do a repeat IVS and see that did it create a cut or not. The luminal gain or the cut created in the calcium or not. Then you can easily tell that is definitely produced a
Yeah,
benefit.
let's go with the IVUS instead of
Sure.
angio, so we can spare some
Sure.
contrast.
Yes.
We take a run of IVUS and we see what we have done so far. Actually, now we are tackling just the aneurysm. We are not thinking about the ostium of the LED. We will do it later.
Samir, in this case, if you do this case, will you do take a cutting balloon at 2.75 or will you just go with a different device to do a different technique? That means you will go with an IVL or with an OPN balloon or some other way to create a luminal gain.
Yeah, so I think, IVL, in my, experience with it, works very well when you have more than,
Sure.
270 degrees of calcium. And here I saw at least 1 or 2 segments where that was the case.
Actually, that is true, but the only thing that's the problem with
Alright,
IVL and
so
European
let's
balloon.
go from here.
Practically, it is not that
Yeah.
easy like
Let's see live.
cutting balloon.
Nice.
Cutting balloon is more trackable in these cases.
That's true. You do
Pull
have
back.
to create it.
Okay.
So the one thing very important actually, listen
So
to
yeah,
pressure is very.
here this is an area that we
If you
have
go for cutting balloon,
treated with the cutting.
It is
There are some
calcium is
nice
back
cuts
down.
here.
Yeah,
Can you
go
see
to
the
five
IVUS,
yeah, yeah,
guys?
then go for NC balloon, then go for
Here we have
OPN,
still some
and you can consider for IVL.
minus. No, please, on the right, keep the basal angio on the right.
Hey,
We
Shimon.
want to see it, otherwise we cannot do a correct
Listen
pullback, okay? No, the
No.
cranial one.
Cranial one.
And don't remove it, never.
Oh, okay.
Okay, so now we are in proxy.
No,
Yeah,
no.
we can stop now. We don't need to stop.
It's-
Stop.
Stop.
We don't need to see it again. Stop.
Okay.
Okay.
Now little bit.
No,
Cranial view
The
also.
cranial view, and don't remove
With
it,
wire,
please.
with wire.
Okay,
Hey,
so
hey,
now
this
let's
one.
see
Hey,
again
this one,
the
this one.
IVUS. I'm
Only
sorry,
this-
but there is an area
think
that
it's
did not,
articulation.
where the balloon did not expand very well. So let's run the pullback. There are some nice cuts just distally of the lesion.
But across the diagonal, you have a distally there is a definite cut.
There are some
Just
nice
the
cuts
diagonal.
distally, but there is still an area that is not very well expanded. Let's put
That is what
let's
Samir
play
was
let's
telling
play
earlier,
it.
that
Let's play
across
it
the
from
diagonal
distally.
there
Yeah,
is a
yeah.
problem. It's
From
not
distally.
inflated properly.
From distally, excuse me, from the
From
beginning.
distally, Shimon.
Yeah. Okay. Now let's see deeply the
Wait, this is plus.
IVUS. You can see here the cuts, which are nice.
এর আগে কি দিছে? Ostial. এর আগে কোনটা দিছিল?
This area is not
Fine, good.
well
Fine, fine.
expanded and is not well prepared, in my opinion.
We have to
This
set.
area is actually more of a fibrotic lesion than a
Let's not complicate
calcium.
our lives.
Yeah,
That part where you are seeing.
Excuse
no.
me, we didn't hear you.
You cannot hear me?
No. Can you repeat, please?
I'm just telling that. Can you hear me now?
Yes.
See, I'm telling that
Let's
the area
do an
where you
ACT.
told it is not inflated properly, that is more of a fibrotic than a calcium.
I agree with you. So now let's see the last angio that we have taken. Did we have a angio after last cut or
No,
not?
no. Take
So
a
now
picture.
we also take a picture, and
Cranial.
so we can merge the information that we had between IVUS and angio. So they are saying the same thing, which is the area in the middle part. Just after the aneurysm is not very well prepared.
Yes.
The area is not good, and as you said, and I agree with you, that lesion is not highly calcific but fibrotic. But actually, we went at 16 atmospheres,
18.
18 atmospheres with a 2.5 cutting balloon. So either we use now a non-compliant balloon. We can
2.5.
try. Yeah.
2.5.
Let's take it 2.5 non-compliant. What do you think?
2.5.
NC balloon.
15. Table আছে.
So once you use an NC balloon and you create a
Yes, yes.
dissection, then
Yeah.
you permitted to do stenting. You told you don't want to do a stenting, you know.
Yeah, we will try. But the decision, as usual, will be taken in the end, after lesion preparation. The goal is to avoid stenting, yes.
No.
Basically, these type of cases, actually, what is the atmosphere you can go with the cutting balloon? I usually go with the 24 and all. But actually, I'm just telling, ox balloon if you use, I don't know whether you use ox balloon, I use ox balloon also. But if you
balloon?
use an
What
ox
is it?
balloon, it is difficult,
Use
otherwise
balloon.
you can take.
Use balloon.
24.
Ox balloon.
Use
ox.
balloon is ox balloon.
Yes.
We
Ox
always
foam.
tell UK
Sorry.
people ox balloon and New York is neo.
Yeah. Well, actually, we would like to avoid any rupture of the balloon because you can imagine
Yes.
the catastrophic consequences of a ruptured balloon in an aneurysm, whose okay, you can leave it.
Sure.
Whose wall is not, very well solid. So,
That's actually, I just wanted to tell you, Bernardo, if you see at IVUS, you
Yeah.
have concentric calcium, the rupture is very less. If you have an eccentric calcium or if you have nodular calcium or a spiky calcium, then chance of rupture is wide.
put on the right.
ছবিটা এখানে shoot করুন।
This is the predictor of the which
Okay.
lesion may.
And stop it, leave it there.
Transform
Not,
into
not, never
rupture.
remove it.
It not sustain.
All right.
That's the problem.
Sorry, we are just fixing a couple of things.
Sure.
From
Yeah.
our
Okay,
young
let's go
fellows,
here.
I would like to ask a question to our
Let's
panelists,
inflate.
whether in
Inflate.
this type of
2,
lesion,
3,
should we go for
Slowly,
first
up to 16.
cutting balloon, or we will
Slowly
try
up to
and
16.
balloon, then go for cutting balloon?
8.
Should be the study in this type of lesion?
Yeah. No,
Okay,
not bad.
if you look at
16.
this lesion,
I think Samir wanted to answer the question.
16, 1, 6.
I think if, in the fibrotic areas
Yeah,
of the
good.
plaque, cutting balloon should work better. Having said
16.
that, at the end of the day, I don't
16.
think the difference is that
18.
noticeable,
18.
especially in the stenting,
20.
era that we live in. So it's very
And why they are moving
difficult
them?
to say which one is a lot better than the other.
Automatically this changes.
I think
This is the
Samir,
machinery
many
problem.
people tell that there is no difference is seen by
No problem, we change it.
schematically, but it is not true. In an ostial lesion,
Let's keep
Definitely.
it a little bit. No, let's
Little
keep
bit
it.
white.
cutting
You're
balloon
at
will
20?
definitely give a
22?
better result than. And when I'm at the scoring balloon, I usually am a strong favorite of the cutting balloon. I use strong cutting balloon in
So what
every
size of
ostial
let's
lesion,
take all the
especially
DCB that we
Lady
have.
ostium
Can
and
you bring them
ostium.
inside?
They do intervention
So
only
this
with that.
They don't available.
One important message we have to remember, once you
Slowly,
find this
slow
sort
down.
of lesion, you can think it might be
সেখানে
fibrocalcification.
DCB তো নাই বলতে।
All of the DCBs that we have.
You can think, if you think that it's osteal lesion, then there is
DCB
no
not
hard and
available.
fast rule which device you should use.
Not available.
Sure, but
There are
not
some-
arrange this.
Regular
It's a
conception and
I have only one
consensus,
DCB.
if it is fibrocalcific
2.5,
or osteal,
2.5,
you go
15.
for first cutting balloon,
So not possible.
then go for NC balloon. If it
crazy.
is wide luminal area, then you can consider for IVL. But if it is less than 2 millimeter,
Okay,
from
that's
the very
semi
beginning,
short,
you can
sure.
go for modification by rotoablation. If it is more than 2 millimeter, then you can consider by balloon dilatation first, balloon strategy. But you should put
DCB
in
not
mind
available. DCB no
if
available.
50% case fibrocalcification,
Company not-
so you
company
should
not
take
cooperating.
cutting balloon first.
That's crazy.
no,
We
no.
have some area. to fix.
Another thing is, if the, according to your question,
বাতাসটা
the
বাতাসটা ফেলেন মানে
calcification
pressure থেকে
is
pressure
to 360 degree,
কেন এই দিকে
then another option is a double luminal insular balloon.
ভালো লাগবে না
Can be used in case of whole circumference is calcified.
Oh, that's incredible.
this but we have
So what are we going to do
Yeah,
from
yeah.
here on, guys?
Another problem is cutting balloon versus NC balloon.
Ostial
NC balloon has
Ostial.
more rupture
Can I see
chance
the
and
last,
dissection
yeah.
chance
last
than
time
a cutting
video
balloon.
No.
I
That's the
Yeah.
advantage
The
of the
last
cutting balloon over NC balloon.
Last
In
time
this
was-
case, he does not want to use an IU. He is telling that he will
The
prefer
last
to use
one. Okay.
Mane-
Just,
regulating
uh,
balloon
after
than
that,
a
after-
stent.
Stop.
In that situation,
Stop.
you always tell that
Stop.
use a cutting balloon
Stop.
rather than an NC balloon.
Go media to media.
Bernardo, what is your
Over
plan
there.
now?
Yeah.
What
Media
are you
to
doing
media.
there?
distal no
Bernardo,
Hello? Yeah.
what are you doing? We are not
We
seeing
are
anything.
yeah, because we were discussing nicely, so we didn't want to disturb you. So, yeah, we have
Prepared.
inflated at 24 atmospheres a 2.5 non-compliant balloon.
We cannot see that. Can you
Yes,
see the
please show to our friends
please show the angiogram.
the angel. Yeah. So this is a little bit better, but not, But we
please
are
show
we are facing another problem here in the cat lab, which is
Manolo,
not.
I am just surprised actually. You used cutting balloon, wool brain balloon 2.510. After that,
You are surprised why?
Again, non-compliant balloon. Took non-compliant balloon.
Hello?
One first. Right?
Hello?
Yes.
Are you
Can
still
you hear
there?
me?
Yeah, yeah,
Yes,
yeah.
yes.
You were saying that you are
You-
surprised. Why?
Why, sir?
You start cutting balloon 2.5.
We cannot hear you.
Right? Okay. Second, you are taking non-compliant balloon, same diameter.
We cannot hear you. Sorry.
Hello?
You are using the same cutting balloon.
No, 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 no.
No, no,
NC,
no.
NC, 2.515.
Yes. First cutting. Okay. Then NC.
Then NC
2.515. You can see it now. Maybe yes. Let's put the last angel.
Last time.
So this is the angel after NC 25. But we have to change our strategy, unfortunately, because we only have. But you said you have one.
One. We have one.
Well, let's use it.
Okay.
Okay.
Oh, no,
Because
no, this.
you don't have it.
Yeah.
Okay. Because the company that should have provided us the DCB didn't provide them. Okay. So far in this cat lab we don't have any DCB. This is
Bernardo,
You are hearing me?
not the best. Yes.
Bernardo, you are hearing me?
Yes.
In our this panelists, there is a confusion. There's in case of fibroelastic lesion or calcified. In these two cases,
Yeah.
where the cutting balloon or scoring balloon, which is more preferable into these cases?
Yes. So we managed the distal calcification seen at the IVUS with a cutting balloon, and the result was good. You can see it now, the angel that is playing. Okay, but the lesion just after the aneurysm. Well, actually, there was at the beginning an aneurysm there, which is more fibrotic than calcific. There are some calcific spots, but it's not a calcific lesion. Didn't respond well to the cutting. So this is why we decided to use a non-compliant at high pressure, 24 atmospheres, 2.5 at 24. And this is what we obtain now. Okay? But
No, I'm want to know that in case of calcified lesion, which either cutting balloon or scoring balloon, which is more preferred?
in highly calcified lesions, I don't use scoring balloons because they are not working. We use either IVL or rotational atherectomy. In these moderately calcified lesions, cutting balloon are working pretty well. And they are working also in fibrotic lesion, actually. But here, in this case, it didn't work as we expected.
Yeah.
So after cutting balloon, we decided to use the non-compliant balloon. Yeah.
Okay.
So, but
Thank
let's
you.
come back again to the
Yeah.
final strategy, because we need not only to prepare the lesion, but to deliver a final strategy.
Yeah.
So I think that we cannot avoid putting stents here. The media-to-media dimension of this lesion measured by
3,
IVUS is 3.0.
3, right? Distal.
No, trio is the distal vessel diameter, right? Distal
Yeah, the
vessel is
media-to-media
3,
distal, which serves as a sizing of the stent. Now we have to decide where to deliver the stent.
to the ostium is this disease, which is nearly 4.5 millimeter vessel, correct?
Yeah.
2 stents.
So the idea is because
Diamismus.
yeah, the idea is to put 2 stents, because I don't think that we can put a single stent from the left main to the mid LAD of the core diameter. What do you think?
Sir, magic come.
I actually, there are 2 ways of looking into these things.
2.515.
Either you can use
Okay.
2 stents with a
Distal.
4 millimeter from the LMCA to proximal LAD and the 3 millimeter distally, or I will lift up, financially there is a problem. I take a 3.5 millimeter stent.
Yeah.
I go one atmosphere less. in the distally.
No,
and take
distally-
out the balloon down.
Distally,
No,
I
no,
think
no,
you
no.
would create
No,
a big
no.
dissection.
Dissection.
Then
No,
I will go with a
no,
high
at
pressure.
3.5, no, we are not going to use it. But
Distally, I take a 3 millimeter balloon and
We
finish
have
it off.
DCB.
yeah, let me open. Okay, guys, so here things are changing very fast. It's like the sky in London,
This guy.
which means that now we have a DCB. So we can
DCB.
interrupt, we can interrupt the discussion about stenting because we are trying to fix the mid-LED lesion with the DCB. Don't touch it.
DCB, why?
Yeah.
Why?
Yeah, we have a DCB, we have a Magic Touch 2.5
But you are,
by
my
15.
question is, Bernardo, you are actually using one stent from LMCA to LED. Why don't you take
Yeah.
one more stent and finish it off?
Correct. But that's the second part of it, no? Now we are fixing the first lesion that we have prepared. And the first lesion, now we see if we can obtain a good result. Let's
Can you-
take the pressure
can you do
here.
one stent in the
the card with
proximal
the
and another
pressure.
stent
Okay.
distally?
Little
Distally?
কাছে আসতে হবে।
Will you do that, Samir? They are actually planning for a one stent from LMCA to ostial LED or proximal LED with a stent, and then distally they are
So
DCB.
actually, I would tell you what I would do in this case for the ostium of the LED.
Go.
But first of all,
But we can use a single stent because nowadays many stents have the expansibility around 2 millimeter. That is, if we use 3 or 3.5
okay, let's
stent, then we can pop in the
Yes.
left main and
Inflate
steer
this,
proximal
please.
Inflate,
LED.
inflate.
slowly.
Slowly.
2,
6,
4.
2, 4.
Yes, but you know, we have seen 2, 4 up to
6,
9 very
9.
slowly.
Okay.
We have seen that
9.
we should avoid paving the coronary arteries of our patients, okay? It's associated with an impaired outcome. You will have for sure a stenosis if you put a 50 millimeter stent here.
9.
Okay, 12, 14, let's take the time.
If you
Okay.
if you decided that you will use the DCB in the LED distal lesion, there is a condition that 70% of the dilation should be done. Here, there is a
14.
70% dilation is done already.
So now we are, I couldn't understand your question actually, but now we are inflating the DCB.
No, his question is actually, when you do a DCB, you have to prepare the lesion well. You aim to
36
luminal
seconds.
gain automatically. The luminal gain is not adequate according to us in IVUS.
Okay, 14?
Luminal gain,
Yeah,
because
but-
3 millimeter vessel, you should have a luminal gain. You understand?
No.
That luminal gain
No,
is
no,
not
no,
there.
no. Not with DCB actually. With DCB we don't, what?
57.
Don't worry. With DCB we don't need to go media to media. We don't need to have the same mindset of stents.
Don't go to media,
Yeah.
but you should have a 70% luminal gain.
Yeah, I agree, but
Luminal.
the minimum 70, I agree with you. Now we can see it after inflation. So you're at 16? Okay, 18
So will you
slowly?
take a 3 millimeter balloon before
No,
taking a
because we don't
DCB?
have it actually. We have to face what we have. So now we have a 2.5, but we are at
18 pressure.
18 atmospheres, which is 2.9, around 2.9. What is it? Look at there. Now look at the cart there. Yeah, look at there.
Again, high pressure, dual check it.
Should be around 2.9 or 3 millimeters. So we keep it inflated for some time. It's almost 2 minutes. Patient is asymptomatic. Okay, so slowly
So-
deflate it.
Slowly, it's deflate.
And then we close, well, we see what we have done.
Yeah.
Of course, if we don't have
Can
reached
you hear me, Bernardo? How long you inflated this DCB? Is it 1 minute or
2 minutes.
2 minutes.
2 minutes? As patient can perceive.
2.64.
Yeah.
Okay.
So
Without
yes,
symptom,
for
no?
2 minutes. 2 minutes, slow inflation, also slow deflation. Now we
Not
see.
bad. Sin.
Let's take a cine. Can you show the cine
Yeah.
to our friends outside? Okay, but still we need to inflate it a little bit more in the proximal.
We
Yeah,
lost
but I
the
agree.
video,
In
yeah.
this case, okay, inflate it. Inflate
Inflate.
slowly to 14.
Yeah.
In this case, my choice would have been a middle. I mean, 275.
Audiovisual,
DCB,
please see
14.
there is no video.
Can you hear me?
Okay.
Hello?
Yes, we
So,
got you. Yep,
yeah,
we
the
got you.
problem here is that we only have 2 DCBs which are just arrived. So one is 2.0,
2, then
slowly up to 18. And the other one is a
2.5.
is a 2.5, which is the one that we have used. So in the best world, we have all of the measures, but not today. So we have to do what we with what we have. So if we have not reached an adequate lumen, we will put a stent.
Absolutely.
Okay.
Okay.
Slowly
Deflate.
deflate slowly, please.
Okay.
How much time do we have? So can we treat also, because I would like also to
Now we are
comment.
agree with you that after violation of the fitting balloon, and if the luminal diameter is properly dilated, then we can use the screen.
Okay, let's
But
take
then
a
ECD.
picture. Now we take another picture and we see what we have done. Still, there is something that a lumen, it's the same place in the same fibrotic area. The area is not.
So these type of cases, what are the two issues? One, it is not wrapping very well. Number two is a rapid recoiling of the vessel. If there's a rapid
What did you say?
recoiling, the only option is to
Rapidly
put a stent.
recoil of the vessel
Yeah,
after inflation
yeah, it's a recoil.
Then-
Actually, it's like after lesion preparation. It's
or
It's
fibrotic
not,
nature of plug.
yeah, it's not adequate, this lumen dimension. So here in my cat lab, I would have used another DCB of a larger diameter, actually. But here we don't have it.
Yeah.
So we have to fix this with
With
the stent.
stent, right.
Yeah. So let's put.
3.
So let's decide from where to where put the stent. So absolutely, I don't agree to put a stent from the left main to the middle LED. That makes no sense.
Okay.
But so we should use a
Cover
short
the
stent.
region, yeah.
Short stent.
And 3.
Let's decide from where to where. So which length actually?
Allow caudal.
What do you think in terms of stenting?
Allow
So
for
do you agree all that we should put a short stent there, or we should leave it as it is?
Or you from IBS, you take information.
No, but from engine.
Yeah.
Seems there is a aneurysmal dilatation is there. So I think it should be covered, and distal to the aneurysm there is also a stenosis is still there. So this lesion should be covered.
Yeah, that's the just where the diagonal branch is starting. Over there is the lesion, which is the one that we have to tackle now. But the question is
actually two questions. What do you plan? Your plan is actually distally you are not having a DB. This we are not using. I personally tell you should take a 2 stents and finish it off. So let's say to LA proximal.
no, okay.
one
The
stent,
distal
distally
part,
one stent.
the distal part has been treated with DCB with a good lumen, with a good result. We have a 20%
Then you leave it.
of
Then you leave
stenosis.
it.
So
Don't
that
do
part,
anything and just put
putting a stent there, it makes no sense because we have
No
already.
stent.
Yeah, in that part. But the problem is in the middle part where we have still how is the ACT? Because
ACT?
408.
400.
400.
Oh, okay.
Excellent.
Sorry, I was asking for the ACT for the heparin. So in that part we have to put a stent. So let's take a stent. Stop. Can you from before the
Yeah, yeah.
aneurysm to just
second aneurysm.
2 millimeters after the lesion. Yeah. So I think let's measure with the IVUS. I think it should be around
Shimon, IVUS
between
measure.
15 and 18.
Proximal to?
Yeah. Yeah, I think
Yeah.
so. Yeah.
Bernardo, I'm
No,
Dr.
no, no,
Sabina.
No.
Hello,
Just
can you
before the
listen to me?
aneurysm.
Can you
Yes,
hear me?
please. Just before the aneurysm.
Before the
What is your
aneurysm.
plan
First
now?
aneurysm before
Which
proximal.
part you do want to stand and where you want to put
Yeah,
DCB?
so this is my question to
make us
you.
clear?
We have our idea, but I wanted to ask the opinion of the panel. So our idea is to put it from before the aneurysm to after the diagonal
Shimon.
branch origin.
সুমন এই যে প্রক্সিমাল থেকে এটা
This is
region
our
বের
idea.
করে সেকেন্ড ডায়াগোনাল পরে একটা
Yeah.
এরিয়া লেন্থ বলেন আমাকে
No. Tell them see a distal part. Distal already there is a lesion, you know. You cannot just leave that part. You have to put a stent from LMCA to LED.
Yeah,
There is no
and-
question that you can
and-
leave the ostial LED.
হ্যাঁ হ্যাঁ, এটা কি ভালো জায়গা
Ostial LED has a significant
আরেকটু
disease
সামনে আসেন।
according to the IVUS.
The
Before the
the
part.
ostium of the LED, you say?
ostium of the LED has significant disease. Can you just look
Ostium
at
LED is
this?
significant. We have to treat
Back,
it.
back.
Yeah,
Yeah,
of course.
this is
নিচে আসেন
in that level, it's almost extending up to the LED distal by LMCA
হ্যাঁ এই
distal
জায়গাটা
part.
এই জায়গাটা কত
So ideally, you have to put a stent from crossover stent, LMCA to LED. Can you just look at the area?
Of the area. Okay, let's take an area. Okay.
That is 3.5
No,
millimeter
of the
LMCA.
left main. Let's take a diameter of the left main, please. Yeah. Yeah, media to media.
Diameter is 4.2. We can tell you 4.2.
Yeah, okay,
or
so no, I think it's larger.
4.2.
Yeah, it's 5.1. So that,
5. Oh my God.
yeah. So I don't know if you do you have a
Proximal
stent
কি
that
রাখা
goes
জায়গা
from
আছে?
5 to 275?
No, I will tell you, you take a 5 millimeter stent from LMCA osteoproximal part, ostial to the proximal.
Yeah, we
LED.
need two stents. We cannot use one single
এখান
stent.
থেকে
of
রাখেন
course.
এখান থেকে অ্যানারিজম
Four
কভার করে
millimeter
ডায়াগোনাল
stent.
পরে কত আসে
4.
কত 27
Yeah, yeah, but okay.
before aneurysm to cross the diagonal
no,
distally
no, he measured from the ostium, not before the aneurysm.
No.
Look at this. Look.
Look.
Yes, so it's much less.
Much
So
less.
we need an 18 millimeter stent, 275 18. Okay, I take the
275
decision.
okay sure make it simple
In the mid portion.
Mid portion.
Yeah.
What
So we
brand
put a
are we
stent
using?
across the aneurysm. So contrarily to what we wanted to do, we put a stent there, and then we have to decide what to do to the ostium of the LED. I have to tell you, I'm not gonna do it because we don't have the device, but in my cut lab, I would have used the same cutting balloon, a larger cutting balloon, of course, a trio in the ostium of the LED. And in case of good lesion preparation, I would have used the DCB also there, because we have a complex trifurcation with a large bending. Can you show the spider view, please, again? So there is a big bending, look, between the left main and the LED, a trifurcation and a quite good discrepancy in the lumen. So between the left main and
There is
LED.
also
So
issues
all of
angle.
this for me is an indication for a DCB if we achieve a good lesion preparation. All right.
So Bernardo, what I understand from your
Okay, leave it.
case, first you just put a DCB in the across the aneurysmal area, then you will decide whether you go for proximal LED and left ventricle, either for lesion preparation. Then you take decision either you should go for DCB again or go for stenting.
No, we cannot go for
DCB.
DCB because the
Not
company
available.
did not provide DCB.
okay
You're ready?
Okay, understand. So
Test.
you have to go for stenting from
Okay.
distal vein to proximal LED.
Inflate up to
Inflate.
4, 5,
Slowly.
6, 8. So this is a 275.
yeah 2018
Okay. What brand of this
or
is?
zero
Orsiro. Okay. Nominal. Okay. 10.
Zero.
Yeah, it's Orsiro.
2.7,
18
Okay.
and
Okay. 12.
three, at least three. I think it go up. I press.
Okay. The small deflate, please. And then let's take. You should do a pot. Huh?
yeah
Agree?
yeah of course
Okay. What is the size just before the aneurysm of the vessel?
Hydro attention from the
3.5.
moderators. Do you have any
3.84.
time to continue this case?
lumen to lumen
You have to finish the
2.5 okay
So we have to stop this session very quickly and so you can study for your strategy.
Okay. So you are coming back later or not?
No, you should come in.
We'll come back to you.
Okay.
Okay, great. So let's
Okay.
take.
So now just give us a final comment. Actually, what is your final plan?
So yeah, now we assess what we have done. We do the
Okay.
pot with a stent in the aneurysm because the proximal part is should be-
3.58
What is the size?
3.5.
Yeah, 3.5.
Yeah,
3.58. That's perfect.
yeah
So now we do the pot for the stent proximally with a 3.5 balloon, and then we start addressing the ostium of the LED. We will decide what strategy to use for lesion dilatation. I don't know. We have to see again the IVUS, because I want to see the lesion, how it is, and then we will put a stent from the left main versus the LED after having protected the other two branches. So this is our strategy. But I hope that you can come back later so we can show you
Come back
the
later,
final
sir.
result.
As we are running short of time, we are moving to the next session. So we call the moderator of the next session, Dr. Saleh Nasreen, Dr. Azizur Rahman Roman,
Okay.
Dr. Choyan Sinha, to come on dais and
Can you
take
remove
over
the
the
audio, please? The audio.
Thank you all. At
Remove
the end
audio.
of this session, we'll see the final
Recording
result.
stopped.
I think this is a good strategy.
Huh?
Good strategy. Your decision is excellent.
Yeah, unfortunately, it went differently.
Because
So, as expected, Orsairo, you cannot see it. Do you have stent boost?
Yeah, we have.
Okay, first of all, let's check with the
Okay.
angel. If we are a little bit more proximal, I think. Huh?
Yeah.
Okay, let's do the stent boost. When you're ready, tell me.
Ready. You seen?
Okay. Yeah, so can inflate this first and then
Yeah,
we can do it more
inflate.
proximal. Okay.
2,
Inflate
4,
at
6, 8,
10, 12,
10.
14,
Right. 14.
18. No. Can remove the stent boost, please? What?
Fluoro. Then it automatically remove. Yeah.
Okay, no, but I wanted to do an angio.
Yeah.
Not angio, a cine. Okay.
Okay.
Okay, down. Okay. So now let's check. Let's do an angio.
Okay.
Now wait. No, wait.
Oh,
We don't
sure,
need it.
sure.
Don't need it. Okay. Ready?
Ready. Yeah.
Okay. Yeah, it's the
Not bad.
yeah. It's the best that we can achieve.
Yeah,
so.
sure. Why not?
Okay, so let's concentrate on the ostium.
Right.
Let's see
IVUS?
again the IVUS, please.
Okay.
We want to see how the plaque is composed
Okay.
and the media to media of the ostium of the LAD
Yeah.
also. Patient is okay, huh?
Yeah. Hemodynamics excellent. ECG pressure.
So how was possible that the ACT was 400?
Main PCI with or without IVUS.
Hey,
Current
A little
sister,
bit more distant, a
evidence
little
and
bit.
practical experience.
sound of course
Dr. Fernando.
How could it be 400?
এই এসিটি আবার করুন তো এসিটি
Okay, just 2 millimeters.
This is just 2 millimeter distal.
Okay, so other two, please. Okay, let's go here media to media. So we have a 5.0 in the left main, and here it's a 3.0, I think.
Huge mismatch.
3.4. Yeah. Yeah.
40 megahertz, sir, so you can use little bit.
lower sir
0.25.
Okay, so
3.25
No,
3.5, okay.
0.25.
okay
yeah, but we have also to tackle a 5.0 left main. What is this?
IVUS you
No,
need?
we have already done it. I
Oh.
think it's enough.
Okay, no problem.
Yeah. So, what type of stent do you have that is able to
Expand more.
Expand more.
Or the more huh? Which one?
Onyx and synergy, these can and also premier LED.
Yeah, you have all of this.
3.5 4.5 gain but dia 5.1
Yeah, bro.
Go up to
up to what
4.5, sir.
Yeah, and for up to 5,
4
what's
can go up to 5, sir. 5.7.
4 is too
No,
much.
4 is too much.
What is
3.5 you check it 3.5 3.5
Onyx
কত
can,
করে?
Onyx can for sure.
3.5.
Yeah.
Onyx,
high
3.5 and expansion. Experience. Sir, Onyx 3.5 can go up to 4.75. And synergy,
that's enough.
4 can go up to 5.75. 3.5 can go up to 4.25 for synergy.
No,
No,
synergy, no
synergy,
way.
Onyx.
No way. Onyx.
Can go up to 3.5
Okay.
can go
Okay,
up to
okay.
4.75.
In the meantime, can I have the other wire to protect?
yeah
Okay, so we use a Onyx for sure, a 3.5. Now let's decide the dimension. Can you measure from the ostium of the left main? Can we see the spider, please, also? They also need. Can I have some more water here?
sure
Okay. Yes. So yeah, let's measure it. Yeah. So now we have to decide. We can also decide to protect both of them.
okay
Huh? Both of the branches.
right
So another
because
one.
use ramas and also LCS dominant LCS Yes, ostials.
Okay, another wire.
Yeah, another wire.
Oh, let me put it
তিনটা wire আছে।
here. Okay.
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 BMW.
All right. So we can take a trio balloon.
Yeah.
15 can be for the ostium of the LED.
Okay. না না ছিল না 315
Small test.
unit test না okay curve is more yes.
Yeah, it's too much bending.
Right. You need torque?
No, yeah, there's a torque, please.
Yeah.
Okay, so how long is it, the lesion that we have to treat?
For LMC to overlap the stent?
Yes.
Yeah. LMC to overlap the first stent.
No, we don't want to cover all. Test?
Oh.
You want to cover all? Test?
Then
can we have a test in the meantime, please?
From ostium to first stent? No. No, back. I'll see. This is no. No. Yes. No.
What wire is this?
The small branches is there.
Want to bend it more?
Knuckling? No.
Stupid wire.
Okay.
Let's do this. Leave it?
Okay. This is shear, no?
No, è sempre quello là.
This is really clumsy. Trifurcation area, there is clumsy area. Angle is not more band go LED, less band go LCX. I don't know. Yes, no.
All the branches?
Yes.
It will be a problem if we have to recross it. Okay, so trio balloon.
315.
Yes.
This is LED.
So how long is the stent again?
How long?
From LED posterior to the first stent overlap.
Yeah. Okay. Let's put the bezel, the angel there, please. Okay. Have it. Yeah. So okay. Let's. If we cover it all. Yeah, okay, let's cover it all.
Yes.
Okay, so how long is it?
From here, this is
Okay, no, from
No,
the
LMC.
ostium of the left main to the other stent.
Yeah.
But you don't know where is the other stent.
This is the left main ostial.
Now we can see. Okay, let's go on cranial, please.
Cranial view.
It is 22, sir.
Huh? 32.
Left main posterior to
First
first
stent?
2 millimeter overlap.
Yeah.
Yeah.
So it's become 22, sir.
But you don't have there the stent. How can you see it?
This is
Okay, okay. So it's a theoretical measure.
Theoretical.
But we can use the balloon. Okay, small test.
Okay.
Yeah. So 1, 2, and a little bit more. Okay.
Yeah.
Test small. Okay, inflate.
Inflate.
This is at 5 slowly at 4, 5. It's a trio.
Yeah,
Okay.
315.
6, 8, 10, 12, 14.
12, 14,
Let's go to spider. 16.
16, 16.
Okay. Okay. Down.
Down.
Okay. Yeah, I think that you said 32.
No, 22. 22.
I don't
Okay.
think so because look at this. This is
Unit bush.
yeah. No, this is 1,
Yeah.
2,
Right.
and a
Overlap.
little
Yeah,
bit
yeah,
more. Yeah, but this is 24.
Right.
This is 12, no?
Yeah, 15. 1 5.
Ah, so 30. Now we have to do IVUS and we measure it again. So IVUS cannot. It's the difference is huge. Okay, have it. Okay. Okay, live. Do you have something here? Some drape? Okay.
Okay.
Record, please. Do you have some pan, something to put here?
Okay. Short sheet.
Yeah. So we can assess also how the stent is managing the aneurysm. So the stent is well expanded.
Well expanded.
Yeah. Is it? Yeah. So there is also some part. Okay. Good. So yeah. Okay. Now we are without the aneurysm. So we still have a lot of plaque there, but
Okay.
it's with the stenting I think we can treat it without problems. Okay, stop. Look at this. So we have to add at least 4 millimeters there.
This is okay, sir?
Yeah, from the
2 millimeter inside of the stent, sir, approximately.
1 millimeter.
1 millimeter. I think this is 1 millimeter. This is 22.97.
Thank you. Excuse me?
22.
Okay, so
23.07, sir.
23. So we add 4. So let's take it 28. So 20. So Onyx 3528.
Onyx.
Onyx 3526 and
26, yeah, or 30. 30 is too much, I think.
Yeah.
So
26.
26.
26. Okay. 26.
So what is it? Another magic touch. What's the measure of this? The measure of this? No, too small. Okay.
Yeah, sorry, last stent.
But they are connected with us?
No.
No.
Sorry, the outside monitor room.
Ah, okay.
Our second live 12. I have
What case
30
do you have?
minutes.
You do it?
Yeah, with Professor
It's a
Mitra.
long day, yeah?
A long day.
আমার সাইজ আছে বুঝছেন
ওই তো 3.5
22 হবে
no
22 এর 30 আছে না
Oh my god. Okay, let's take it to 30.
26 ঠিক আছে
30.
আদার স্টেন কি আছে এক্সপ্যান্ড হয়
Unless the trio, I don't remember if the trio of Onyx. No, it's 375. No,
Onyx,
we have-
Onyx?
Yeah, it starts from there.
3.5 or 4?
Yeah.
Onyx can go up to
no 3.5
Okay, let's take 3530. That's the only one.
3.30.
yeah
Unless you want to use Ultimaster, I don't know if you have it. Or a Biomatrix, do you have it?
Biometry আছে নাকি ভাই?
No.
sir.
Unless you want Angiolite, I don't know it. You have Angiolite?
Angela
Is it okay for you if you use Angiolite? No?
no problem
No problem. So what size, what dimension, what length do you have with a 3.5? I think also a trio is okay. Angiolite trio.
326
Yeah, 26 or 28. Yeah.
5.25
What is the Angiolite? Who is
Wow.
producing it?
Angiolite which company
Which company is Angiolite?
Abluminous
No, Luminous is Concept.
oh concept Ibis
Ivasco, yeah.
yeah
29.
24 and 29
Yeah, okay. 29.
29
The trio?
35 yes
Trio?
Trio,
Take a
trio.
trio. Let's see if we have more measures. No, I know Ivascular is a good company. It's a good stand. I think. But I don't understand. We don't have the DCB today. We organized this 2 months ago. Okay, so the 29, please.
Okay.
So I don't understand how is it possible.
I
So
contact
the
our
device are in the country
Yeah.
because yesterday Dr. Moshid enrolled 4 patients in our trial.
Right.
So in the country there are devices.
other center
Yeah, but they could take from another
Take from
center
right,
and
yeah,
bring
sure.
here. No?
Why not? But they don't cooperate. I contact with Patho and our local Shubho.
So they said they are unable to provide this amount of GCB right now because they are providing everywhere. So they are out of
Yes,
no,
but
this
if
is
they
not
have
issue.
them at Dr. Fazila Malik's hospital, they
Mm.
take them here and bring
Yeah,
it here.
right,
This
right.
is what I asked them. This is an important live case.
Live
It's
case.
important for all of us. It's important for the company. so-
Patient also.
Yeah, mostly. All right. Okay. So nominal here is what?
Nominal কত এটা? 9.
Okay, bring it very closely that I can read it, please.
এটা সামনে হ্যাঁ
Okay. So yeah, nominal, let's say it's 10. Okay, so 16 and 370. Okay, good. All right, so here it seems nice.
Yeah,
Okay,
yeah,
let's
yeah.
go cranial, please.
Cranial, please.
Ra-
Allocranial.
Areocranial.
Allocranial.
What do you need?
Take care. Okay.
No, RAO. R.
Arok.
Why is this down? Pull it up. Okay. Let's go. So let's take
Pick. Bush.
boost, stand boost.
Stand bush.
I go?
Yeah.
Ah,
no
fluoro,
problem.
sorry.
No problem.
Fluoro?
Fluoro.
Okay.
no
I
Yes,
can
yes.
go? Okay.
Sin. Okay. Yes, overlap is there, 2 millimeter.
No, I cannot see it. I cannot see it. So let's do it again. So tell me when you're ready.
Yeah.
Yes, ready, sir.
Sin,
Please follow the sir.
I know.
sin. No.
It's moving too much. Yeah. Seems okay. What do you think?
Sir, this is wire, 3 wires, so all are count.
Ah, okay, that's it.
Not a good view.
Nah, but
Let's try this. Let's try this.
Bush, again bush.
Okay, okay, push it a little bit. Let's try again.
Sin, okay.
Okay, sir.
Bush.
Ready.
Eastern bush.
Sin, eh?
Yeah,
Yes,
sin.
sin.
Okay.
Yes, overlap, more overlap. 8.
More or not?
Oh, it's a small the overlap.
Yeah, more overlap.
2, 3.
It's okay now.
Yes,
It's okay now.
It seems 1.5 millimeters maybe. Yeah.
Yeah.
Okay,
no
let's
problem.
inflate this slowly for
Fluoro.
slowly for
4, sir.
okay 6. Let's go to nominal.
Now 10.
It's 10, 8, 10.
10.
Okay.
All right. 11.
11, sir.
Let me take a China. Okay. Down.
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 Okay.
Okay. Inflate here. 4,
4, sir.
5, 6, 8.
5, 6, 8. 8, sir.
Down. It's too much contrast for this big balloon.
Yeah.
Takes a lot. Okay, inflate 10,
Inflate. 18, 20.
4, 6,
10,
How much?
12,
10, 12.
12,
14.
14.
Okay, down. Okay, now let's take a pot. Let's do a pot.
4.5.
Let's do first a spider, then we see the other branches,
Right.
and then we take the pot.
Instant already gain 5, no?
And 5 will end, right?
Pot for what die balloon?
Okay, let's see the spider, please.
Okay.
Right. So let's take this angel.
Sure. Not bad. I must pinch, but
Yeah.
Dimitri established ECG normal hemodynamics.
Yeah.
Okay. Excellent. Not bad.
Okay,
Not
so
bad.
now let's do the pot.
Pot 5
5 is big.
big to 4.5.
Yeah, 4.5 is
8,
better.
4.5
Very
is-
short one.
8.
4.58.
Good
It's,
result.
it's a pity, yeah, but I wanted to do full DCB.
4.58.
Yes. So ACT is okay, heparin is okay.
Sister, ACT
Can we do a heparin immediately? 2000.
2000, 2.5. হেপারিন দিয়ে দেন হেপারিন
অনেক আগের কথা।
এখন দিয়ে দেন
হেপারিন দিয়ে আবার এসে
দিয়ে দেন এক
Okay.
1.5 ঘন্টা হয়ে গেছে
I have it.
Yeah.
All right. Let's do this. You can. Perfect. I'll remove a little bit of contrast. Okay. I need the small test.
Back. Above the carina.
Okay, let's go here.
Yeah. 2, 6, 8.
So the
12.
big question will be, yes, 12,
12.
14,
12, 14,
18,
16, 18,
20, down,
20.
down. The big question will be the ostium of the LED.
4.5 down, balloon.
Yeah. 4.58.
Huh?
Yeah, that's okay.
Yeah. So we can assess it with the IVUS. Huh?
Okay.
Let's do
Right,
IVUS.
Yeah. Ostium of LED under oil opposed or not?
It's not crosses.
Yeah,
Excuse
okay.
me? Yeah, yeah.
No.
The expansion
Yeah,
of the
yeah.
LED.
Okay.
All right. Okay.
Okay.
I can record, sir.
Yes.
No, let's see live.
Like, sir.
1 second.
Yes, yes.
All right. Okay. Let's go.
Record.
Okay. Yeah. So the first part we have seen before is the
yes,
DCB
yes,
treated,
yes.
which is okay. So this is the stent, no distal dissection, good expansion. Yeah, this is the unfortunate part
Unfortunate
of
part,
the
yeah.
aneurysm.
For patient and also operator.
So a patient should go for DAPT or very
Right.
prolonged DAPT.
Sure.
Lifetime.
Okay.
Okay. So yeah.
Ostium, ostium. Yeah. Hey.
Yeah.
Fine.
Okay, so yeah, stop it. The length is perfect.
Perfect.
So 26 was perfect.
Perfect.
Because IVUS doesn't see the first part of the guiding catheter inside of the vessel. So
right.
this is why I added 4 millimeters to your
Yeah,
measure.
yeah.
So let's see the ostium. Yeah, the proximal LED and then coming back to the ostium. Yeah, from here. Yeah. So still
Back,
here
back,
it's
back.
okay, well opposed, well expanded, ostium
Yes,
okay.
yes, excellent.
Yeah, and then let's see, left main is well opposed.
distal.
Seems very good.
No, no, excellent.
Right?
Yes, fine.
Let's take a cranial view.
Okay, cranial.
Aorocranial.
Arocranial.
Can I see also the trifurcation with the IVUS? I wanted to see
Ostium of ramus and
how is the
LCX.
appearance of it.
This is the first, actually.
It's
very
one.
visible.
Huh? Yeah,
Is
but
it-
it's open.
it's
We
open.
can see
Yeah,
that
this
it's
is
open.
open, definitely
And the other one, where is it? The other vessel.
LCX.
Sir, if you take a look at this long view, sorry, there is the one segment which has been, this is the start, sir.
Yeah.
Yeah.
Maybe this is
Ramus?
Yeah, yeah, yeah.
LCX.
1 and 2.
Ramus.
I
Oh,
agree.
no, no, excellent.
I agree.
Okay.
So let's
Arocranial.
position this. Patient should move the head, I think, on the left.
Arocranial. Fluoro.
Okay. So
No, oh, yes, yes.
second, let me take it off this too.
Yeah, yeah.
Okay. Okay, so we can take an angel. Okay.
Yeah, sure, ready.
All right.
All right.
Okay.
Diagonal pins, huh?
Yeah, yeah.
No.
This we expected, huh?
Expect.
It's okay. This
But it's feeding.
Spider, sir?
Yeah. Let's go for a spider.
A
Yes,
spider.
please. But we have. Can you attach the audio, per favor? They are looking at us. So. Okay. Let's take this. You're ready?
Ready.
Hello?
Yeah.
All right.
Nice.
Yeah, it's pitch the Ramos. but
Ramos.
it's okay. Hello? No.
Then quad স্যার চলে আসবে স্যার প্রোগ্রাম
স্যার প্লিজ
আমাদের কাজ শেষ স্যার ভাই রোগীর নামানোর জন্য লোক দেখেন
রাহান
হ্যালো
জুম কানেক্ট করো
সব লেখেন
এরা কথা বলতে যাচ্ছে ফিড দাও এলইডি তে ফিড
Hey guys, can you hear us?
আমার কথা শোনা যাচ্ছে
Hello. Hello? Can you hear us?
কাজ শেষ করে
No. They cannot hear us.
Sure. Now we can't hear.
So we
So
finish?
we finished. Because next case only 15 minutes.
Right. I understand. Okay, so
Okay.
thank you.
Thank you
It was
very
a
much.
pleasure. I cannot give you the hand, but thank you for all. Thank you, guys.
Thank you very much.